Welcome to this webinar on congenital or infantile esotropia in 2024. This webinar is presented to you by the American Association for Pediatric Ophthalmology and Strabismus and by the International Strabismological Association. My name is Andrea Molinari. I'm the president of ISA and director of the fellowship program in pediatric ophthalmology and strabismus at the Hospital Metropolitano in Quito, Ecuador. I am going to co-moderate this webinar together with my friend, Dr. David Plager, professor of ophthalmology at Indiana University in Indianapolis and a past president of AAPOS. Good morning, David. How are you doing this morning?
Good morning, Andrea. I'm well. I know it's early where you are, so a special good morning to you. Before introducing our distinguished panel of speakers, we would like to give you a little background about each organization presenting this webinar, and perhaps how you can become a member should you wish to do so. AAPOS was founded in 1974 and currently has nearly 2,000 members, 367 of whom are international, representing 70 different countries. We would certainly look forward to seeing many of you at the next meeting of AAPOS in Salt Lake City in March of 2025.
And ISA, which was founded in 1966, is the only world organization exclusively dedicated to strabismus and binocular vision. It has over 460 members from 70 different countries. You can join our membership and enjoy our case discussions, video club, etc. every month by entering in this webpage and clicking on Join ISA. Our next meeting will be a joint meeting together with ESA, the European Society of Strabismus, in Toulouse, France.
The recording of this webinar will be available on the AAPOS and ISA websites free of charge. It will be up shortly after this is concluded this morning. If you have any questions during the presentation today, please type them into the Q&A box that you will find in the lower part of your screen. The panelists will try to answer these questions either by typing the answer in the box or during the discussion, which will be held after each presentation. So, now without any further delay, let us introduce you to our distinguished panel of speakers. The first up this morning will be Kyle Arnoldi, who is Chief Orthoptist at the Ross Eye Institute in Buffalo, New York, and Deputy President of the International Orthoptic Association.
We will also have Dr. Gena Heidary, and she's the Director of the Pediatric Neuro-Ophthalmology Service and Director of the Pediatric Ophthalmology and Strabismus Fellowship Program at Boston Children's Hospital.
Representing the great Midwestern part of the United States, Dr. Stephen Archer, Professor of Ophthalmology at the University of Michigan in Ann Arbor.
And representing South America, we will have Dr. Cristián Salgado. He is professor at the Catholic University in Santiago de Chile.
Dr. Seyhan Özkan is a former professor of ophthalmology at Adnan Menderes University and is past president of both the ISA and ESA.
And from England, London, England, we have Dr. Jill Adams, and she is honorary consultant at Moorfields Eye Hospital in London, and she's also the vice president of ISA. So now I'm going to stop sharing my screen, and we will start with our first presentation from Kyle Arnoldi. She's going to talk on tips and tricks to get the most valuable information in infants with congenital esotropia.
Thank you to Drs. Molinari and Plager for inviting me to contribute to this webinar. Today I will be presenting the evaluation of infantile esotropia, tips and tricks to get the best information. The age of the patient when they present with any type of strabismus will always determine our priorities and our strategy. Today, I'm going to be talking about evaluating infantile esotropia when it presents in an infant. I hope to give you some useful modifications to the sensory motor exam to assist in evaluating visual acuity, eye alignment, and ocular rotations. We don't really have a good way to assess binocular vision in the strabismic infant in the clinic, but this doesn't become very important until after the eyes are aligned surgically. Then we face the challenges of assessing the development of fusion post-op, as well as evaluating visual acuity. These are very important topics, of course, but I will not be covering them today due to time. Given the importance of vision, should we be attempting to quantify visual acuity in all of our infants with esotropia? That's probably not necessary in most cases. We use visual evoked potential and teller acuity cards. These methods utilize minimum visible stimuli, which is notorious for overestimating visual acuity. They are particularly unreliable in detecting most types and severities of amblyopia, and that's our main concern. So they may be impractical and unnecessarily time-consuming. They are valuable, however, in infants with suspected cerebral visual impairment, organic vision loss, or even just nystagmus. Instead, we tend to use qualitative methods, and this works very well in almost all cases. The most common cause of decreased vision in infancy and childhood is amblyopia, and amblyopia is almost always unilateral. Fixation preference suggests amblyopia is present if it is in the presence of an amblyogenic risk factor and in a child under age 2 years. Children 2 years and older, fixation preference testing may be misleading. So we examine the ocular motor response to visual stimuli, specifically when the child is binocular and therefore has the opportunity to choose which eye to fixate with. But what if you can't occlude the child? What if you can't even approach the child? Well, you could hang in there and hope for spontaneous alternation. Or you could try what you might call the dynamic cross-fixation test. In this test, we introduce an interesting toy in the field where the preferred eye, the dominant eye, likes to cross-fixate. Get the child's attention, and then we move that target through the midline and all the way into the opposite field. We're going to be watching to see when that child switches fixation. It doesn't much matter exactly where the fixation switch occurs. What matters is symmetry. So once we've done this, we're going to take the target and move it back in the opposite direction. We want to see that the zone where the fixation switch takes place is mirrored when the target is presented from the other side. Hopefully, this zone will be somewhere in the midline, but it doesn't have to be exactly in the midline. When it comes to eye alignment, prism and alternate cover testing is the gold standard if it's done correctly. It is the most dissociating of all the tests and therefore most likely to reveal the full deviation. It is the least subjective and controls for accommodation, unlike most of the others. In my opinion, it is also easiest for the examiner because it's easier to detect small amplitude refixation saccades during the alternation of the cover. That is easier than detecting a millimeter or less displacement of a corneal light reflex. You can absolutely complete an accurate, complete prism and alternate cover test on an infant without any modification, especially if you make an effort to use a higher pitched tone, very quiet, appear calm and relaxed, smile. And I like to use the sticker on the nose technique shown here. This tends to catch the attention of the older child or older infant and frees up both hands of the examiner. But what if you're losing cooperation and you can't complete the prism and alternate cover test to neutralization. Well, you could switch to a corneal light reflex test, but keep in mind when you do that, you're likely to underestimate the deviation by as much as 15 prism diopters. Another way to approach it would be to use the Peekaboo Simultaneous Prism and Cover Test, or SPCT. This test can be done very quickly, which is a big advantage when working with infants. It is very important when doing this test that you use appropriate occlusion. If you have to use your hand, make sure you use the palm. You want to cover the entire peripheral field. But most critically of all, you must measure to reversal. If you think that you are no longer seeing an abducting refixation saccade, keep adding more base out prism over the non-dominant eye until you are sure that you see that eye begin to adduct to take up fixation. Only then do you know that you've got all the deviation that's there. This is a very effective test, very accurate, but it can be difficult if the patient tends to frequently and spontaneously alternate fixation. As far as the preoperative evaluation of ocular rotations, we know that our infants with infantile esotropia probably have normal ductions and inversions, but we really do want to make sure. We want to know that abduction is full in both eyes. We want to detect any oblique dysfunction that might need to be addressed surgically. The first thing I consider is the odds. The likelihood of isolated, persistent, congenital or infantile bilateral 6-nerve palsy in an otherwise healthy full-term infant is very low, especially compared to the likelihood of large-angle infantile esotropia. So probably it's not the 6-nerve palsy. When it comes to oblique dysfunction, that is very common in children with a history of infantile esotropia. It tends to present later in infancy or childhood. In fact, in many cases, it doesn't appear until after the first surgery. So again, the odds of it being there in infancy at that first visit are on the lower side. But what if you really want to make sure and the abducting eye won't fixate? Well, the next thing I do is look for corroborating evidence. A unilateral or bilateral 6-nerve palsy absolutely should result in some form of lateral incompetence. And we don't necessarily need to quantify it in all these fields of gaze. We are looking for gross incompetence that would support the diagnosis of 6-nerve palsy. Significant oblique dysfunction should be associated with an alphabetical pattern and with alternating vertical strabismus inside gazes. Pursuit of a small toy or image into the cardinal fields is probably the most common method we use for testing versions. But remember that other eye movement systems can be recruited to evaluate the eye movements, the ocular rotations. And we're very familiar with these already. We can generate an OKN with the drum or a spinning chair. We can occlude one eye with a patch and recruit the VOR, or we can use reflexive saccades to a novel visual target. Reflexive saccades to a visual target can actually be quite effective in detecting lateral rectus weakness. Now, the amplitude of the saccade is going to be reduced unless the child switches fixation. But you're not looking at the amplitude of the saccade. You are looking at the saccadic velocity. You're going to compare the velocity of abduction of that esotropic eye with adduction of the preferred eye. The difference in saccadic velocity will be obvious enough to the examiner's naked eye if there is a true lateral rectus weakness. I usually repeat this several times using new targets and toys just to be sure. I like using these toys here. These are little animals on long, clear plastic rods. The rods are actually quite long. I like this because I can hide them underneath me while I get the child's fixation on my face and make eye contact. And then I will suddenly introduce one of these toys into the peripheral field and watch the eye movements. I'm essentially evoking saccades, and then I'm going to compare the saccadic velocity between the adducting and abducting eye. This is a test that can also be used to evaluate peripheral visual fields in an infant, but I don't use these targets for the dynamic cross-fixation test. They're just too large for that. So to conclude, when you need to be a magician and pull a rabbit out of your hat to get the data that you need for your exam, try these modifications and see if they work for you. For visual acuity, try the dynamic cross-fixation test and look for symmetry of that switching zone. For alignment, use the peekaboo simultaneous prism and cover test, but measure to reversal to ensure accuracy. And for ocular rotations, look for the corroborating evidence on your exam, but try evaluating abducting saccadic velocities. Thank you.
Thank you so much for that excellent presentation, Kyle. You know, it's interesting you make that sound so easy. Oh.
Yes, that was a great presentation. Kyle, you said that amblyopia is not so often in those infants with congenital esotropia, and that is also my experience, because most of them have cross fixation. Here in South America, we have many of those type of congenital esotropia that we call ciencia syndromes that has very large angles, and all of them have cross fixations. So, but there are sometimes children that don't have such large angles, and in those cases, some of them might have amblyopia. So when you suspect amblyopia in these infants, what management do you recommend before proceeding or deciding to go to surgery?
Oh, you know, there are a lot of factors that I'm going to consider when deciding what management. For me, compliance is the most important thing. So my preference really is occlusion with the adhesive patch. But I'm also a realist, and I know that a lot of our families are not going to be compliant with that. And so I am a fan of atropine penalization for these kids. You know, it's interesting that you bring this up about the large angle esotropia and the cross fixation versus the smaller angles. It is, in my experience, the smaller the angle of strabismus, the more likely it is that the child will commit to one eye and then develop amblyopia, which is why postoperatively I'm so concerned about their vision development, because you take a cross fixator, straighten the eyes out or nearly straighten them out, and now we're sort of setting them up to develop amblyopia. I think it has to do with the amount of visual field overlap, creating a competition in the visual cortex for those afferent neurons, you know. So that's when I really become concerned. But yes, to answer your question, I'm sort of old school when it comes to amblyopia therapy. I do think that patching early and often to kind of do it early, get the vision equal rather than prolonging it, you know, which is in an infant, if you have to use atropine for penalization, then that's what you do. But I do think patching is best.
And this question goes to all panelists too. When you recommend patching, do you recommend, and let's say it's an infant of 6-7 months, you recommend how many hours per day? You recommend patching only on the fixing eye? And Seyhan, maybe you want to answer that question? You raised your hand.
Thank you. Well, actually, I was going to ask a question, but as for answering your question, I also prefer to go on with patching, and the hours of patching is absolutely depending on the level of fixation preference. But in the very early time, I may even do just 1 hour sometimes. and usually 2 hours. But if it is required, then it even more than that. But the important point is, if you prefer longer hours, you need to see those kids more frequently. So the aim is, as soon as you get the alternation, it's over. And may I skip to my question to Kyle? And Kyle, thank you for this. Was an excellent presentation. And I would like to learn your opinion about the refraction in these kids. Because, I mean, in our practice, the most common point of mistake is actually not to have a good refraction for these children. So whatever you use, if it is these, I mean, in our experience, if you refract these kids with pediatric autorefractors, this is one of the major common source of error. And on the other hand, with retinoscopy, the major challenge is to have an on-axis, to stop off-axis refraction. So I think this is an important point to mention. And I would like to learn your opinion on that, how to refract these children, these infants.
That's a very good question. So I didn't think to include this in my presentation. What I do, it takes a lot of patience. I always prefer, regardless of the age of the patient, I prefer retinoscopy over any type of autorefraction. When it comes to the very young children, I have little toys. Many of them are intended to be like the wrist rattles that they make for babies with Velcro, that I attach to the retinoscope so that they have a target to look at besides just the light. You know, the room lights are dim or off, so it's even better if I can get one that lights up. But yeah, patience and persistence. The very young child, I sometimes find that it's not that difficult to get their fixation. It's when they get a little bit older, and they're looking around a little bit more. That's when I'm more concerned. And of course, a child presenting at that age, you don't know, it could be an early onset refractive accommodative as well. That's it. Actually, that brings up a question that I have for the panelists. If you are refracting, let's say we have a 6-month-old with a large angle esotropia, how much hyperopia in that refraction would make you think, I want to try glasses before, going to surgery? What is your threshold for that?
In a 6-month-old,
yeah,
maybe, or for diopters of hyperopia in my case.
4 diopters. Well, in my case, I always correct if it is around 2. And because I always remember a statement of Jampolsky, and I cannot remember sharply, but I remember his statement that he says, I always overcorrect these infantile kids. So whatever you do, and there is, we sometimes, with the best refraction, we miss some part of the hyperepic refractive error. So if it is over plus 1.5, I try to put the glasses. And if I see any instability on the deviation, I try to overcorrect as +1. And it's amazing that some of those kids do so well with it, but this is actually the amount that we missed during the refraction examination.
Thank you, Seyhan. Unfortunately, we have to move on. There are some questions at the Q&A box. Some are regarding Botox, and this is going to be addressed at the final presentation. So let's move on. And now we will go on with the talk of Dr. Gena Heidary on causes and risk factors for congenital esotropia.
Hello, thank you for the opportunity to be part of this panel today. I'll be talking about the risks and causes of congenital esotropia. I really appreciate the invitation from Dr. Molinari and Dr. Plager. This is my financial disclosure. I received royalties for a recent textbook entitled Fundamentals of Pediatric Neuro-Ophthalmology. I'd like to review the epidemiology of congenital esotropia and briefly review several hypotheses on the causes and underlying etiology of this phenomenon. First, let's talk about milestones of ocular development. We are familiar with the fact that initially in normal development, infants exhibit strabismus in the first few months of life. And so this idea of congenital esotropia or esotropia immediately at birth may be a misnomer. Dr. Archer and colleagues looked prospectively at the ocular alignment in over close to 3,000 babies and found initially that many had variable angle esotropia, exotropia, and this typically resolved esotropes by 2 months of age and exotropes by 6 months of age. This is consistent also with the congenital esotropia observational study conducted by PDIG, where surprisingly the number of children or infants who were enrolled who had the classic constant large angle esotropia with the clinical characteristics that we'll hear about from Dr. Archer really were fairly few in the patients in the study. And so some have proposed that we call this condition essential infantile esotropia rather than congenital. With respect to epidemiology, there have not been global studies looking specifically at the incidence of essential infantile esotropia. In the United States, there have been several isolated studies. So for example, in Olmsted County, Minnesota, where the population is predominantly white, colleagues found that the incidence was 1 in 403 live births during a 30-year retrospective study. There have been several multi-ethnic studies conducted both in Baltimore as well as in California. And in the multi-ethnic study, looking at any type of esotropia, in those children who were 6 to 11 months of age, it was found in 0.3% of Hispanic babes, 0.4% in African American children, and this study indicated that exotropia was more frequent than esotropia in these children. And the Baltimore Eye study, which looked at a cohort of white children and African American children in the 6 to 11 months of age, they found that it was present in 1.2% of white children and none of the African American infants whom they studied. More recently, the British surveillance ophthalmologic study found that the incidence of essential infantile esotropia was about 1 in 9,000 live births annually. So quite a bit less frequent than it reported in the United States. Out of these studies has emerged some risk factors that should be considered, including a history of prematurity. And this is really distinct from prematurity with subsequent neurologic sequelae that then leads to or is associated with strabismus. So this is prematurity in and of itself, low birth weight, family history. And as of yet, there is not a specific locus that has been identified for essential infantile esotropia. Dr. Momini looked at 173 pedigrees where the probands all had congenital esotropia and found in her analysis that the majority of inheritance patterns would be most consistent with an autosomal recessive inheritance pattern, followed by some cases of dominantly inherited infantile esotropia, followed by other non-genetic causes. Several of these epidemiologic studies also identified maternal smoking during pregnancy as a risk factor. When considering etiologies, there have been many great thinkers in our field who have tried to put forth hypotheses regarding underlying causes, and I will summarize just several here in this talk. Historically, we think about early 20th century thinkers Claude Worth and Bernard Chavas. Dr. Worth proposed that there was an intrinsic defect in the fusion mechanism that could not necessarily be overcome by surgical correction, whereas Chavas suggested that the fusion mechanism was intact, and therefore if we pursued early restoration of alignment during this period of development or period of reflex learning, we might be able to promote binocularity. And so that was a more sort of hopeful approach, and this was extended and seized upon by Dr. Kostenbader in the United States. And in his seminal paper, where he retrospectively reviewed 500 of his patients with infantile esotropia, he put forth that many of his patients who underwent surgery attained motor fusion, growth stereopsis, and even high-grade stereopsis. And this really formed the basis and impetus to support early surgery for congenital esotropia. If we think about more contemporary hypotheses, Dr. von Norden in his Bowman lecture suggested some blending of Wirth and Chavas. And here in this figure, we see in the center that we start off with what we were talking about earlier, that early in development, the visual system and the motor system is immature. And that therefore, the system is vulnerable to factors which promote strabismus, shown in this rectangle, either excessive convergence, a high AC/A ratio, refractive error. And so if those strabismogenic factors are present, we shift to the left where we have defects in the development of motor fusion, esotropia, and then subsequent impact on the development of cortical inputs that promote binocularity. Dr. Brodsky draws our attention to this idea of monocular nasotemporal asymmetry, or an underlying bias that exists early when the motor system is not fully developed and the subcortical circuitry is really dominant. This subcortical circuitry has optokinetic asymmetry and a nasal-ward bias of the eye. If cortical inputs do not develop and binocularity does not develop, then this subcortical circuitry basically takes over or persists, if you will, and that nasal ward bias results in convergence and isotonus. Finally, in the recent Jampolsky lecture from Dr. Guyton in 2022, he revealed data from scleral search coil recordings in 10 patients with dissociated vertical deviations and discussed that the etiology, really understanding the response of how the eye damps the horizontal component of fusion maldevelopment nystagmus or latent nystagmus. So to improve vision and damp nystagmus, there is chronic convergence. This then leads to a foreshortening of the medial rectus muscles and subsequently persistent esotropia. So overall, in reflecting on these hypotheses, we know that we are closer to understanding the pathogenesis of essential infantile esotropia. And certainly by identifying risk factors, it allows us as pediatric ophthalmologists to be more proactive in screening at-risk infants and hopefully providing the interventions to promote good binocular development, which we will hear about in subsequent talks. Thank you so much.
Thank you, Gena. That was a great talk. About the epidemiology, about the the frequency, because this is something that is frequently discussed in strabismus meetings, that the congenital esotropia is not so frequent as it used to be before. I was surprised to see that Dr. Kostenbader's thesis was on infantile esotropia. Infantile esotropia is something we in the developing world, in South America at least, we see very often. I see at least one child every day. What about you, that you work in a big university center? Do you notice that the frequency of these pathology is really decreasing? How often do you see, I know you're many ophthalmologists there, how often do you see congenital esotropias in your hospital?
Well, thank you for the question. You know, I've been thinking about this, and actually, I'm surprised that we see it less frequently than I would expect. And, you know, I was trying to think on whether this has to do with, you know, do we have better maternal care? Is there a reduction in prematurity, for example? Is there better understanding of, you know, the risk associated perhaps with maternal smoking during pregnancy? I'm not certain. You know, part of, I think, the fallacy of these epidemiologic studies is that they, you know, this is probably also under-recognized, and maybe these children don't make it to us as early as they should. I think that happens as well. And in this recent British study, they tried to correct for this underreporting by making a modification in their estimate to account for the fact that maybe these children are not being referred as quickly as they should be. So I also wonder if it has to do with referral patterns and a recognition by our pediatric colleagues that these babies need to be seen early.
Regarding maternal care, I also thought about that, but you know, I'm seeing two very different socioeconomical populations in Ecuador, because I work at a foundation where we see very poor children, and I'm in my private practice where I see patients with a high socioeconomic level, and I see congenital esotropia in both of those populations. So I'm not so certain about, but I think it might have something to do, but you can also see congenital esotropia in a population that have a good socioeconomic status. Anybody, anything else to say about this? Cristián?
Yes, it's very interesting. Thank you, Gena, for the talking. In Chile, surprisingly, I've seen that the incidence of congenital esotropia is very low. In the last 10 years, I think I've seen one patient per month. And in 20 years ago, it was about one per week. And I don't know why, but I think the XT is getting more frequently in kids, surprisingly. I don't have an answer for that, but in Chile, it's very low too.
David, how is it up in Indianapolis?
You know, I'm from the old school, and I'm kind of the opinion that we don't see it as much as I feel like we used to when I was younger. Now, maybe it's a reflection of there's more pediatric ophthalmologists now, so they're spread out more, but I really don't feel like we see it as much as we used to. That's totally anecdotal. There aren't any good numbers, but.
There is one question from the audience. Gena, is there a sense that infantile esotropia is more common now in neurodiverse kids? I think this is neurological impaired children.
Well, yes, I thank you for the question. So I really tried to focus on the, let's say, classic definition that where neurologic function is intact and normal. But there definitely is a cohort of children whom I see in particular who have an underlying proclivity, I think, for strabismus because they have a history of neurologic disease. Either they may have CP, they may have had hydrocephalus in the setting of prematurity or other neurologic conditions. So I think that that's a distinct cohort where we certainly see esotropia occurring, but I really feel that the behavior and the outcomes and kind of the interventions for these children are a little bit different from that classic essential infantile esotropia patient.
Okay, we probably should try to stick to our schedule here as much as we can. There's a lot of interesting questions. Feel free to put them in the chat. But we'll move on to the next talk, which will be Dr. Steve Archer and his presentation on clinical characteristics of congenital esotropia.
My topic is clinical characteristics of congenital esotropia. The definition of congenital esotropia, attributed to Kostenbader by Parks, is a constant large angle esotropia with an onset less than 6 months of age. These are the clinical characteristics that I'm going to be talking most about in this lecture. The other requirements are that this be non-accommodative, and there are some other associations that develop later that we'll also discuss. So this is the typical picture that we think about when we talk about congenital esotropia. Young baby with large angle esotropia, they will often cross-fixate, as you can see in the right-hand picture here. They seem to have a little bit of aversion to abduction of the eyes, so this can sometimes be mistaken for limitation of abduction. So they have a large angle esotropia when they present to the clinic, but wasn't really present when they were born. The question of whether the deviation is really conatal has been debated for quite a while, and we tried to answer this in a large study in the nursery that we performed several decades ago. What we found in this study is that there were 2 babies who had esotropia at birth, but both of them had their deviation resolved by 2 months of age. We did have 3 babies who developed congenital esotropia in this study, but none of them were crossed at the time of birth. Here's an example of one of the babies with esotropia as a neonate who was straight 2 months later. Here's an example of a baby who developed congenital esotropia, but was straight in the nursery. So if the deviation is not always present, we don't know that it can't be sometimes present, but at least most of the time it appears it is not present at birth. Is the term congenital esotropia correct? This has been debated quite a bit as well, and it has caused the development of a number of terms for this condition that have been used variably in the literature. I'm not in favor of gratuitously changing terminology, so I stick to the traditional congenital esotropia term. We're not sure that this is wrong because we don't know whether the condition that causes the esotropia is present at birth or not. But the problem with changing the terminology is you lose connection to the vast amount of literature that already exists. So if the deviation is not often present at birth and shows up somewhere between 6 months, how does it develop? This question was answered to some degree in a PDIG study in 2002. This is cross-sectional data from that study, and what they found is that babies presenting with esotropia at 1 to 3 months of age were often intermittent or had variable esotropia. The babies who presented at 3 to 4 months age were more frequently constant deviations, and the babies who presented at 4 to 5 months were largely constant esotropias. The natural history of how this evolves has been looked at a little bit by Birch and in the PDIG study. And what they found is that if the deviation, if the esotropia is less than 30 prism diopters and it's intermittent or variable, then it will sometimes resolve. Sometimes as much as 50% of the cases will improve. Rarely does it resolve if the deviation is greater than 40 prism diopters and it's constant. This is a plot of both of the studies that I've discussed on the same graph. The blue line is normal babies, and it shows how normal babies are a little unstable in their alignment. They're often exotropic early on, and then as time goes on, fewer and fewer of them have any misalignment, and by the time they get to be about 6 months old, they're all straight. On the other hand, the babies with esotropia start off variable and intermittent, and then as time goes on, more of them are constant esotropia. And so what we see is that babies with esotropia, as they're consolidating their esotropia, are doing that at the same time frame as babies who are normal are becoming straight. Now, if you take the derivative of this blue curve here, what you get is the rate at which normal babies are becoming straight. And that's what you see in the green line here in this graph. And what we see is that the normal babies are becoming straight fastest at about 2.5 months of age. Now, the upper panel of this graph are babies who had an examination by a pediatric ophthalmologist prior to the development of their esotropia, either as part of a study or by accident. And that puts a lower limit on when the esotropia could have developed. The other end of these bars is the first examination by a pediatric ophthalmologist when they had esotropia. And so each of these bars gives a range over which the esotropia may have developed in these babies. And what we see is that these bars really overlap at about 2.5 months of age. So again, it appears that babies with congenital esotropia are becoming esotropia at about the same time that normal babies are becoming straight. Now, the size of the deviation normally is thought of as being large, but these are the data from classic Jim Mims study of dose response curve, and it shows that the peak deviation is somewhere between 30 and 40 prism diopters. This was also looked at in the PEDIG study, and they found a more even distribution of deviations. But if you break this down by age, again, the babies presenting at 1 to 3 months of age had a peak, small peak, roughly at 30 to 40 prism diopters of esotropia. Those presenting at 3 to 4 months are starting to shift a little bit. And then by the time the babies present at 4 to 5 months of age, the 50 prism diopter or greater bin is the greatest in this histogram. So there are a number of other associated findings with congenital esotropia. That's why some people like to call it a syndrome. Most of these are attributed to disruption of fusion during a formative period for visual development. The first one is inferior oblique overaction, which again has been a victim of gratuitous terminology change, is now referred to as over-elevation in adduction in some places. The presence of inferior oblique overaction at less than 4 months, as gauged by a number of different publications, there's a wide variety of papers that contributed to these numbers, is fairly low. And by the time babies get to be over a year of age, about 3/4 of them have inferior oblique overaction. Latent nystagmus is fairly similar. It's also been a victim of gratuitous terminology change. It's now referred to as fusion maldevelopment nystagmus syndrome. The babies with congenital esotropia who are under 4 months of age rarely are identified as having latent nystagmus, although that may be more a difficulty of examination than it is presence of the condition. For children with congenital esotropia over a year of age, I wasn't able to find good statistics for this. My sense is that it's quite common, maybe even approaching 100% if you look closely enough for latent nystagmus. Dissociated vertical deviation, again, is rarely present in babies less than 4 months of age, but once they get to be over a year of age, almost 3/4 of them will have dissociated vertical deviation. Amblyopia is the one condition that does show up fairly frequently in babies less than 4 months of age, and of course needs to be looked for and treated. So in summary, the esotropia in congenital esotropia develops somewhere between birth and 6 months of age, and it looks like it's most often around 2.5 months of age. The esotropia as it develops may be intermittent or variable, and smaller deviations, especially if they're variable or intermittent, can resolve spontaneously. The size of the deviation varies more than we had realized. The deviation as the esotropia develops, however, may tend to increase.
Thank you very much for that, Steve. Excellent wrap up and discussion. Going back, picking up to the discussion we were having before the last one, Steve, you've been doing this for a long time and looking at congenital ET for a long time. What's your feeling about whether this is as common as it used to be, or is that just anecdotal?
Yeah, I've got almost a 40-year perspective, and it's very much less common than it was when I started in this. And the reason for that is unclear. There are more pediatric ophthalmologists. I don't get the sense that they're seeing enough to explain the difference. And if anything, I would expect the presentation in my office to increase, because when I started, congenital esotropia was considered a fairly simple strabismus, and a lot of general ophthalmologists would take care of that, and we would never see those patients. But I don't know of any general ophthalmologists who want anything to do with strabismus anymore, so they would all be coming to us. So if anything, I would expect an increase in the number from that standpoint.
Regarding the DVD and the overaction of the inferior oblique, which is so common in these patients, do you sense that both of these characteristics, or both of these dysfunctions come together, or do you see first inferior oblique overaction and then DVD might appear?
Well, they're both so common eventually that it's hard to know whether there's a causal relationship between them or not. I don't think I have any good data to say whether one develops first or the other.
Yeah, and sometimes as you say, it's difficult to differentiate both of them in very small children, where you cannot do a properly cover test and evaluate the movement in the different gaze positions. But for example, I think that they are so frequently tied together that when I have a patient, an infantile esotropia with congenital esotropia and inferior oblique overaction, my procedure of choice of weakening the inferior oblique is by anteriorizing them, just in order to prevent a DVD to occur. Any other panelists have another opinion regarding this? And then we move on.
You know, the interesting thing, we talked about the prevalence of congenital esotropia decreasing, but the prevalence of DVD has also decreased quite a bit in my experience. When I started out, I was doing probably at least one surgery a week for DVD, and I rarely do anything for DVD now. It's probably a couple of times a year I do surgery directed at DVD. So the incidence of that has decreased even more than congenital esotropia, I think. So I don't like anteriorization as a primary procedure. It has some other complications that often develop later that I don't like, and it causes bulging of the inferior lid, which is sometimes cosmetically an issue. So that's not my initial procedure for inferior oblique overaction.
Okay, very interesting. Thank you so much, Steve. And in order to keep on schedule, let's move on to our next presenter, which will be Cristián Salgado, that will talk on a very controversial topic, which is when should we operate in congenital esotropia? Because this is different in different parts of the world.
Hello, and thank you to all the people who is attending the webinar today, and also the organizers, to allow me to talk about when should we operate in congenital ET. So the goal of this talk will be to identify the clinical characteristics of patients who undergo surgery, to recognize the benefits of surgery, and also to compare pros and cons of early versus late intervention. So the first thing I want to address is what is the natural history of the congenital ET. This study done in 2002 recruited patients with different size of deviation, as you can see here, and also different type of character of deviation in constant, variable, or intermittent. So what happened here? They found that patients who had intermittent esotropia had a high amounts of spontaneous resolution compared to patients with variable deviation, and the people with constant deviation had the less amount of spontaneous resolution. So as a overall group, all patients with esotropia in this study chose a 27% of spontaneous resolution. But if the patient had ET between 10 weeks of age or 6 to 6 months, or a constant ET of 40 prism diopters, or refractive error less than 3 diopters, only 2% of the patient had a spontaneous resolution. So what is the goal of treatment in the patient with infantility? Of course, the ocular alignment. And why? Because in this amount of deviation, we can restore, improve, or to get binocular vision. And how the binocular vision develop or loses in these patients? Well, the age is something that is important to get into account. In 1985, this study compared the prevalence of stereopsis in post-age patients, normal post-age patients, and you can see here how the stereopsis develop normally. But compared with isotropic patients tested with prisms before surgery, you can see that the drop in stereopsis occurs about at 4 months of age. Also, in this summary of surgeries done at different ages and prevalence of stereopsis, you can see here that the older the baby, the less the probability of having a good stereopsis. These are different studies done in different years. And this study is very interesting. It was done in 2000, and because it was done in about 129 isotropic patients, a prospective study, and they studied the age as a function, the age of onset of strabismus as a function of the prevalence of stereopsis, and also the age at alignment as a function of prevalence of stereopsis. They found no more difference at this variable. They found that the older the baby, the less probability of having or achieve a good stereopsis, but mainly because the main factor that they found to be important to achieve a good stereopsis was the duration of misalignment. So if you do surgery early, probably you have less time of strabismus, and that's the reason why you have better stereopsis. So how much time you can have a baby with a strabismus to get a good stereopsis? 3 months. 3 months approx. You can get 65% of good stereopsis. But if the deviation long about 12 months, you only get 4% of good stereopsis. And also they said that the lack of stereopsis give you more risk of horizontal strabismus, GVG in 2.5 times. And also in 2004, the same group addressed the importance that having no stereopsis, the risk of reoperation for recurrent ET or consecutive ET was 3.6 times. So if the age at surgery and duration of misalignment is very important, why we can do surgery in all patients about 3 to 4 months? Well, because it's not easy to do it, because you know that patients always, or the most of the time, present to our office in these conditions, crying, having a bad time. So it's difficult to evaluate these babies. There's a lot of people who have a variability of the deviation, and also we know that we can get some spontaneous resolution too. In some places, the anesthetic risk is an issue, and also there's technical difficulties in doing surgery in such small babies and ocular globes. And also that you don't forget that the best binocular status that you can achieve in most of the patients is a monofixation syndrome that you already know that has these characteristics like central suppression, peripheral fusion, and stereopsis in the range that you see there. So most people in other countries say, well, if I'm going to get some monofixation syndrome, either way, doing surgery before or after, why bother in doing surgery early, right? So this study in 2005 was done actually in Europe. It was a multicentric study, prospective and not randomized, to compare what happened. Patients treat early. They define early surgery in the first 2 years and late surgery in about almost 3 years and older. And they found that if you do surgery early, you can have better gross stereopsis in both groups. But the fine stereopsis, the number 4, 5, 6, and 7 in this graphic, is about the same. And also they address that people or babies doing early surgery have more probability of having more surgeries than doing surgeries in a late time. Having these problems into account, also they said that there's more options to have, like you see here in the black bars, a consecutive XT or recurrent ET. So people, according to this study, say, okay, I don't want to do more surgeries in these babies. I'm going to do just one surgery in a late time. So to address this problem too, in 2006, this study compared early surgery before 6 months and standard surgery before 1 year, not 2 years. This was 2 comparable groups, and the post-op outcomes were very, very, very interesting, because you can see here that the alignment was pretty much the same in both groups. No additional surgery was different in both groups, but the stereopsis and peripheral fusion and random stereopsis was much better in the early surgery group. We know that it's hard to get a binocular vision 100% normal, but it was better than the late group either. So having said that, I think that in my preferred practice is, if you have a patient between 4 to 6 months and the deviation is constant, you can try and to do the surgery. And also, if the ET is not some constant, but it doesn't improve, do it as soon as possible. You have to feel comfortable with your measurements. If the variability is still a problem, you can do the surgery to the, like a target angle of the greatest angle you have, or you can use Botox, and I think that's an option. And don't forget that you can get a better binocularity and stereopsis if the misalignment is less than 3 months, like we saw in the previous study. So still some people do surgery in a late time because they want to minimize the need to operate multiple times, right? Of course, if DVD and inferior oblique coexist, you can do only one surgery. And in developing countries also, the access to surgery is more difficult sometimes. So I hope you can get all the goals of this talking, and I'm happy to answer any questions that arise. Thank you for your attention.
Thank you, Cristián. That was a very interesting talk and very controversial. I travel very frequently to Germany, where many people do operate late. But I wanted to say something about what you said on the ALICE study, and especially on the reoperations, because they say you have to reoperate more often in the early operated children. But remember, this study, all the children where the final outcome was evaluated at 6 years of age, which means that for the early operated children, they had 4 years of follow-up. They had 4 years to develop DVD, an inferior oblique overaction, or a consecutive exotropia, or a recurrence of ET. And the late operated children, they had only 2 years of follow-up. So I don't think that you can be so sure that only by operating the children late you will have, because if you check these children, let's say 10 years afterwards, maybe they have the same reoperation rate. What do you think about that?
I agree with you, and also the dropout of patient was very high in the late group. So I just put that work because to say to the people that there is another approaches, right? And in my case, I think you should try to do a surgery as early as you feel comfortable. But also I understand if people want to do surgery late, and it all depends what is the goal of your surgery. That's what I put there. If you want to try to get some binocular vision or improve it, or to keep some kind of binocular vision, you have to do surgery early on. But if you want to do something like a motor alignment and some social, psychological issue that's just align the patient, okay, you can do it later. But yes, that's what I think, actually. I think you should try to do it at least less than 1 year if you can do it before.
Yeah.
I don't know what the other people think, but...
Seyhan, please go ahead. Unmute yourself.
Thank you. Well, actually, by means of early surgery, the two advantages of early surgery is usually underestimated. One of them is it is nice to demonstrate that these kids, when they are aligned, show greater motor and developmental improvement. And this was very nice to demonstrate it in a study by Bird's group, and also in another study number of patients from Italy. And the other point that I think it is usually not mentioned in most of the studies is that those with large angles usually develop secondary restrictions. So if you wait for a long time, these patients ends up with this restrictive problem, and you need to shorten the conjunctiva. I think shortening the conjunctiva is a major issue that actually has not been studied in long term, whether these children would have some dry eye problems when they get older in their lives and so on. So these secondary restrictions decrease the predictability of the surgery, so that I'm going to talk about this in a couple of minutes. But I think this is also a factor that needs to be considered about considering earlier surgery.
And the psychological aspect that Cristián just mentioned that is almost never mentioned. There is a very good paper from Martin Lederman in the Journal of Pediatric Ophthalmology, an old paper, I think it's from the 80s, referring to this aspect, the relationship of the child, mother, and father connection in children that have the eyes crossed, the limitation of abduction, the cross fixation, they cannot connect as well with their babies.
So, I would also caution us a little bit about how we use these terms early and late surgery, because one of the studies that Cristián presented, kids between 12 and 24 months were in their early surgery group, and in another study that was considered late surgery. So that only further muddies the water at how we look at these things. So now that we have a sort of a unanimous agreement on when to operate on this child, we're going to hear from Dr. Özkan about how to operate on these children with surgical techniques in congenital esotropia.
Dear moderators, dear colleagues, I'd like to thank the organizers for the kind invitation to speak at the AAPOS ISA joint webinar. And my topic is what to do next when the decision for surgical intervention is done. After refractive correction, the options are surgery, surgery plus toxin, or toxin only, and the major problems with surgery are over and under corrections, secondary restrictions, and unrecognized or late onset vertical deviations. There are a number of procedures that is used for treatment of infantile esotropia, but what is the most effective type of intervention? When we look at the evidence-based guidelines, we see that there are no straightforward guidelines and it is unsatisfactory. And as for reoperations, the major risk factors are amblyopia, large angle of deviation, DVD, and maybe timing of the surgery. And the reoperation rate increases with longer follow-up time, and it may be even over 60% when the follow-up is over 15 years. In large angles with cross-fixation, secondary restrictions is a problem, and alternating occlusion may be a useful measure to prevent medial rectus contracture and shortening of conjunctiva. In those with a short conjunctiva, conjunctival recession may be necessary. And secondary restrictions increase the effect of surgery and reduce the predictability. So these two patients underwent by medial 11.5 millimeters of recession from the limbus. And despite the patient on the left-hand side has a larger deviation, ended up with a consecutive exodeviation who had a secondary restrictive element. And this was controlled with toxin injection afterwards. And the one on the right-hand side demonstrated a good long-term result. And this patient on the left-hand side also demonstrates why not to choose 3-4 muscle surgery as an initial step. And if there are accompanying vertical deviations, surgery needs to be planned accordingly. And inferior oblique weakening is required in case of inferior oblique overaction. And the most common method is inferior oblique recession. And myectomy should not be used, not to sacrifice the muscle tissue, because we may need to have inferior oblique muscle afterwards in future. And some prefer to use inferior oblique anterior position as an initial procedure to prevent possible future DVD, but this may end up with asymmetrical results. And unilateral inferior oblique recession or anterior position carries the risk to induce inferior oblique overaction in the sound eye. And in case of a DVD, either inferior oblique anterior transposition in those with inferior oblique overaction or superior rectus recession may be used. There are a number of controversies in infantile esotropia. Bimedial recessions versus recessive sex surgery. How much to recess the medial? What is the most efficient and safe method to increase the amount of surgery? Faden operation or polyfaden? Why splitting? Is it worthy for more invasive procedure? 3-4 muscle surgery, is it a real requirement? And toxin augmentation, is it a fully safe procedure? So if we look at the bimedial recession and recessive sex surgery, the bimedial recession is the most commonly used procedure, and it directly addresses the contractile force symmetrically, and it is possible to combine it with superior rectus recession. However, the major advantage of recessive sex surgery is on reoperations. It is more predictable on reoperations. And despite there are some controversial reports, the randomized control study demonstrated that both of these procedures have similar effect. So this patient with a large ESO deviation underwent 11 millimeters of bimedial recessions from the limbus, and then 6 years later she presented with residual ESO deviation. And she underwent bilateral inferior oblique disinsertion plus bilateral small lateral rectus resections against the previously recessed medial rectus muscles, which ended up with a large large response with consecutive exodeviation, which was then controlled by toxin injection. And how much to recess the medial rectus muscle? So limbus insertion distance variabilities needs to be considered, and the measurements from the limbus seems more advantageous. So the 11.5 millimeters from the limbus is considered as the maximum conventional amount, and this should better be considered as 10.5 millimeters for small infants under 1 year of age. And supramaximal recessions has a higher risk for overcorrection. And even conventional recessions may be challenging in small infants with large epicanthal folds, and in those hangback sutures may be a good solution. And our choice is to use FAST technique in hangback sutures. It is technically easy. There are some described modifications for the technique, and it cannot be used in combination with botulinum toxin. So this is the disadvantage. And what is the most efficient and safe method to augment the effect of surgery without increasing the reoperation rate? So these are Faden operations, polyposterior fixation, Y splitting, and these three may be used in cases with variable angles, and plus botulinum toxin augmented recessions for X large deviations. Botox operation is a well-known technique since years, and it can be used either with or without recession, or bridge Botox is also possible without muscle suture. And when Botox operation is used as the only procedure, the reoperation rate is quite variable, 5 to 45%. And the problems of this procedure is technically challenges, high risk for scleral perforation, possible risk for induced scar tissue. And pulley posterior fixation seems a more safe procedure. And this surgery can be used with or without recession. And pulley posterior fixation was found to have more favorable results compared to augmented recessions. And the problem is lack of consistency to reach the pulley tissue in an infant eye. And in wide split of medial rectus muscle, the medial rectus muscle is split into two halves. Up to the pulley area is 15 millimeters. And then these split halves are sutured at the intersection point of two circular lines, midpoint of insertion, and the second one 6 millimeters behind the insertion on a given radius. And the aim is to reduce the torque. And while the idea is good and the results seem satisfactory, and Badawi compared the results with Botox operation and recession, and they reported similar results, but the authors also indicated that it is difficult, time-consuming, and requires experience. And the major problem is complexity of the calculation, invasive technique, and obviously the reoperation challenges. Botulinum toxin augmented recessions is a technically easy procedure. With this technique, the contracture of the antagonist increases with possible increase in sarcomere alterations, and the early overcorrection is a key for successful outcome. And I prefer to put the scleral sutures first, and it is a technically straightforward procedure. Lueder reported a larger series looking for the toxin augmentation effect, and they reported that successful long-term results with less consecutive exotropia rate compared to supramaximal recessions. And this table is from Lueder's study. And this table also includes our study, our initial study, which included 7 cases of esotropia. And in our report, the amount of medial rectus recession was just 5 millimeters, which was less than the other reports, with a little bit of less success rate. And this table shows that the supramaximal recessions, 3-4 muscle surgery, and toxin augmented surgery all gave similar results. And Hunter's group calculated the amount of toxin augmentation in surgery, and they found that toxin augmentation adds 1.7 prism diopters of correction per millimeter of surgery. And they also reported to have more favorable results with toxin augmentation compared to 2-3 muscle surgery. But is toxin augmentation fully safe? So this case is a late presented in infantile esotropia. This is a case from our original study, and she was fine in 1.5 years. And then she presented 13 years later with consecutive exodeviation, A pattern, and DVD. And we found that she had a scar migration problem, and the medial rectus muscle was resected and advanced with bilateral superoblique posterior tenectomy and right superior rectus recession. Then this was her final result. So the take-home messages are: inform the parents about long-term follow-up. There's no universal agreement on surgical choices. Avoid supramaximal recessions. Always consider possible reoperation in your surgical choices. Toxin augmentation seems a less invasive and relatively safe choice for X-large deviations. And I'd like to invite you to our live surgery symposium on 6th June, and there will be free online access. And then next year in next June to ESA AAPOS joint meeting. Thank you very much for your attention.
Thank you very much, Seyhan. That was great. You've presented us with many options. Curious your personal preference. If you are presented a 4-month-old baby with 50 prism diopters of alternating esotropia, how will you handle that, and when will you do it?
So thanks, David. Well, actually, if I see a patient with such a large deviation with 4 months of age, well, first, after refractive element is over, I certainly prefer to do alternating occlusion in order to prevent the secondary contracture of medial rectus muscle and also shortening of the conjunctiva, because they never do abduction. When they are cross-fixate, they don't move their eyes and towards abduction. So, and the other point is my choice of timing of surgery is around 1 year. But sometimes I can go as early as 9 months, but never before 9 months. And my choice is to stay around 1 year of age. And my nevers are, I never do supramaximal surgery. I never do 3-4 muscle surgery at the same time. If I must say that at around, even for 75 diopters and so on, my maximum amount of medial rectus recession is 11.5, and my surgical choice is by medial recession. If I have even larger deviation than that, my choice to increase the amount of surgery is to add botulinum toxin, not to go on 3-4 muscle surgery and so on. Regarding the Faden operation, I don't do it as a primary choice. Regarding Y splitting, despite there are some nice reports, I don't think that, well, it looks so invasive to me, although the especially in Germany, our colleagues use it quite common. But I must say that even though I don't have experience with medial rectus Y splitting, I had quite a lot of experience about Y splitting of muscles in Duane syndrome. And I've seen reoperations with Y splitting of lateral rectus muscle. And well, I can say that it's not a nice thing to reoperate an already Y-splitted muscle. And I must say that I wouldn't wish to be the one to see a patient with infantile esotropia having no surgical notes and who had a previous Y-splitting of medial rectus muscle. And I think it could be a quite big mass. And the amount of split is 15 millimeters. It's not a non-invasive procedure. So this is, my nevers are like this. So as another, can I go on if you permit me? Because there was a little bit of discussion in previous talks that Andrea asked about the inferior oblique anterior position and so on. Well, I see the idea of the primary inferior oblique anterior position as a preventive measure for future DVD, but so any kind of restrictive surgery may end up with asymmetrical results, because without knowing how much DVD will appear in which eye, it may go on with asymmetrical results. So this is how I experience in those kids. And as another addition to your question, David, if I see any inferior oblique overaction, or how do you call, whatever you call as elevation on adduction, and I certainly address the vertical element as well. So I weaken the inferior oblique. I don't choose anterior position as a primary procedure. But recession is my favorite for that. And regarding, there was a question about the Q&A and whether it's where the surgery could prevent for development of future DVD and so on. I have seen so many patients who had, after years of good alignment, developed DVD in one of the eyes and so on. So I think it doesn't prevent it at all. But the point that I need to mention is that the good follow-up is so important in these children, because when you see the initial signs of DVD in one eye, with just making some occlusion in the other eye, you can easily provide the symmetry despite the patient do not have any amblyopia. Or as for reoperations, DVD is the major risk factor for consecutive exodeviation. So when you see little signs of A pattern, little signs of just 2-4 prism diopters of exo on down gaze, if you just reduce the refractive correction, you can see in time that you can stop the loss of fusion in these children. And I think good follow-up has a major influence on that.
Thank you, Seyhan. Well, we don't have much more time for more questions, but I just want to say some very short. I just did this week a wide splitting of a media rectus. I don't think it's such an invasive procedure. It's much faster than to do a FADN, and it's a fantastic procedure for operating on children that have a high ACA ratio. It corrects the disparity, the near-far disparity, very nice. So let's move on to our next talk on role of Botox in congenital esotropia, presented by Dr. Jill Adams.
Good morning, and thank you for asking me to join this symposium on congenital esotropia. I'm going to talk about the use of botulinum toxin, and we use Dysport at Moorfields, so I have removed the Allergan logo on the original title. It's an uncommon condition, and a recent UK survey showed an incidence of only 1 in just under 13,000 births, which is considerably less than a study at the Mayo, which showed it as 25 per 10,000 births. We need to distinguish it from neonatal misalignments, which means we may have to wait before intervening in a patient's care. The goals that I think we would all set ourselves are to have no amblyopia, eyes within 10 prism diopters of ortho, and stereopsis if it can be achieved. So I'd like to look at the use of toxin in 2 situations as an alternative to primary surgery and as an augmentation of primary surgery. At Moorfields, we use Dysport, and when I inject, I give 2.5 units and 0.1 mil of saline. I now give it under ketamine, which means no laryngeal tube is required. I do use EMG control because I have it available and I think it is safer. But I am aware that some people will just use Mendonca forceps to grasp the medial rectus, taking the eye into adduction. You know you're in the muscle when you feel a pop, rather like you would if you put a fork into a sausage. I leave the needle for 1 minute to stop the fluid leaking out, and then I get the child sat up as soon as possible to prevent ptosis, which occurs in about 50% of medial rectus injections, and I put a stat dose of ointment in case they rub their eyes, having had a drop of local anaesthetic. The complications are ptosis. I have never had long-term ptosis, and we haven't induced amblyopia in any child. Subconjunctival hemorrhage is common, but a use of some topical adrenaline does help in reducing this. I really like to see the child being divergent in the first week after the injections, knowing that this is likely to give the best outcome. You can get some induced vertical deviation, which will settle. I've never had a baby or a very small infant complain of double vision, although they may shut one eye, but a child who is older may well say that they're seeing 2 parents. Serious complications are extremely rare, although there is one case in the literature of a child who was a -24 myope in each eye, having a perforation, getting endophthalmitis and a retinal detachment. That case was not done under EMG control. The history of toxin for infantile esotropia goes back to Alan Scott, and in 1980 and again in 1990, he reported outstanding results of 2/3 of his patients being successfully aligned. McNear got even better results with nearly 90% of his patients aligned to within 10 prism diopters. However, A large study by de Alba-Campanaz only found 45% successful, and they found that it was more likely to be successful in smaller angles. Mayet, in recent publications, has not found such a high success rate. Around about a quarter of their patients were successful. And our national prospective study, which only found, as I say, 57 patients in 1 year, we found no statistical difference between the outcomes of surgery and toxin, despite what the percentages looked like there. The systematic reviews come down to saying that it's a good option for a moderate angle, which they defined as 30 to 35 prism diopters, and that, as I've said, you might expect to get ptosis and consecutive divergence. But it was a safe and worthwhile procedure to consider. Does the time you inject matter? Well, there are papers saying yes, there are papers saying no. I think my feeling would be that if I had the option, I would opt to treat early, because I think that if we believe that early alignment is better, earlier toxin treatment has, of course, got to give you, I think, a better chance of a good outcome. It's considerably cheaper and it's considerably quicker. And I know you're going to look at this and think, I don't spend 72 minutes doing this. Well, I don't either. But this is total time, as our scheduler would look at, from entry into the anaesthetic bay, having the operation, and coming out on their way to recovery. And this was timed the whole journey, 11 minutes for toxin and 72 minutes for surgery. So it's a much quicker intervention, and as I say, it's much safer because you don't have to paralyze the child, you don't have to put a mask down. So it's quicker and cheaper, and you can get more patients done in your scheduling time. Does it make any difference if you've had toxin and it's not given you an optimal outcome? No, it does not appear to have any negative impact on your later surgery. So you can use it, and if it's not as successful as you would like with the correct alignment, then you can go ahead to surgery without any concern that it is going to damage your surgery. Interestingly, we've looked at our long-term outcomes in a group of children at Moorfields, and we use a lot of toxin in infantile esotropia, and about half had surgery, half had toxin. And we've got just under 5-year follow-up. But the interesting thing that we found at the last follow-up, one child remained very slightly divergent after toxin, but was still aligned within 10 prism diopters. But about a fifth of these patients who'd had surgery and no toxin went on to become consecutively divergent. And remember, many of them had been undercorrected at first review at the longer-term follow-up. We got no patient who had toxin and then went on to have surgery who became consecutively divergent within this time. So I think you can consider it as a good first option with less risk of the long-term negative outcome of consecutive divergence. I think the other time that it's very useful is augmentation of large angle squints, which I would define as 60 or more, and you can put it into one medial if you're doing a recess-resect, or both medials if you're doing bimedial recessions. You can either do this open sky, in other words, you can do it when you've opened the muscles up for surgery, before you assess them. Personally, I prefer to put it in the anaesthetic room so that it's got less chance of leaking out. After I've given it, the anaesthetist then puts the child to sleep with a laryngeal mask, and I go and scrub. It saves you having to do supramaximal recessions, which we know carry the risk of long-term consecutive divergence, or even doing 3 or 4 muscle surgery, which is further longer time in theatre and more muscle destruction and scarring. So if we look at our goals, there is no evidence that if you give your child toxin that they will become amblyopic or have any negative effects on their vision. If you look at the papers, It's good for angles of 30 prism diopters or less, and you can use it to augment the very large angle squints where two muscle surgery is unlikely to be successful. Stereopsis, well, some papers have reported that 2/3 of the patients treated will get 3D vision, but I think that is more likely to be with early surgery. So I think it's a very useful tool to have for management of infantile esotropia. I think it's best initially either when you've got a variable deviation or a smaller deviation. It doesn't require a general anesthetic. You can do it with ketamine, and it's very quick. It's safe. It doesn't give any scarring. It doesn't involve any cutting or moving of muscles. It gives you less risk of consecutive exotropia in the long term. And if you do need to, you can do surgery after toxin without any adverse effect on outcomes. I do think it's something that you should consider using in infantile esotropia.
Thank you, Jill. That was a very good talk. And there were several questions in the question and answer box. But I have one question first. Which is the youngest baby you injected with botulinum toxin?
It'll be around about 5 to 6 months, but not usually.
Okay.
But I'm very happy to do it in a variable angle. That's one of the joys about toxin. You don't need to wait for stability. And we wouldn't operate on muscles before 6 months. So you can do it earlier. But I think as Steve referred to, there's the neonatal misalignments which are settling. You have to be certain you're not going to treat a child who doesn't need treating.
David?
Yeah, Jill, I enjoyed your colorful description of sticking a fork in a sausage, but I must admit that that's not a sensation that I have often appreciated. Is there a particular needle that you use that allows you to feel this pop into the muscle?
Well, we do it under EMG control. So we've got an EMG needle, and they're very fine. And you do on unoperated on muscles. It's the key to knowing you're in the muscle, and you're in the muscle belly, and it really does give a pop. Once you've done it once, obviously, again, like going into the sausage, you're not going to get that pop, but and you can see it visibly. You can see the jump on the EMG as you do it.
There's another question on the Q&A box regarding what about those infants that you see and you already recognize that they have inferior oblique overaction or DVD? Do you still inject those cases or you go straight to surgery?
No, I mean, I think DVD is something you tend to see later, but I would be very happy to deal with the horizontal angle with toxin.
And if you recognize an inferior oblique overaction?
Well, you can put toxin into the inferior oblique. I haven't done it in very small babies. I've done it in adults. But I think if you're seeing DVD, that's a later phenomenon. I don't think you see that it's not commonly seen in the very young kids that we see, very young infants.
Thank you, Jill. Well, we are already over time. I hope everybody enjoyed this talk, this session. And David, would you like to give some final remarks?
Sure. As Gena mentioned before, early onset esotropia has been a topic that has fascinated many of the most prominent minds in strabismus for many decades. Frank Kassenbader's AOS thesis in 1961 was titled Infantile Esotropia. Gunnar von Norden's 1988 Jackson lecture was titled A Reassessment of Infantile Esotropia. And Gene Helveston's 1993 Kassenbader lecture was on the origins of congenital esotropia. There have been others, Brodsky, Guyton, others. But, I think what we've learned from our panelists here today is that in 2024, we still have many well-considered opinions, but many of the real answers regarding the conundrum of congenital, infantile, essential esotropia remain. I would like to again Thank all of our panelists for their excellent contributions. Dr. Molinari for her leadership in arranging this symposium. Ashley and the AAPOS staff for coordinating the logistics of today's program. And to all of you for sharing your time with us today. So from me, good day or good night, depending on where you are. Enjoy the rest of it.
Thank you.